protection in the cardiac catheter lab? Thank you both.
Thank you very much. Perfect. So thank you very much for inviting me to talk on PPE in the cath lab. What I'll try to do following the previous talk is just to show us some of the background data that we have and perhaps offer some pragmatic discussions on what we think is the best for our cath lab team. So what we really want from our personal protective equipment is really make sure that our healthcare workers are protected against the disease whilst offering excellence in cardiology care. And that's very important. We need to make sure that whilst we protect ourselves, we still remain giving patients the best of care that we can do. And unfortunately, without trying to be too dramatic, we've already discussed this, there's a significant proportion of healthcare workers infected, with many doctors having died in Italy and a few starting now in the UK. So the risk of exposure, particularly to acute specialties, which we can include cardiology, is very high, particularly because we are exposed to high viral loads and also repetitive loads. So what you don't want to happen is one of us getting ill. Now, how do you understand how the COVID is transmitted to us, and what is relevant to our PPE? So there are largely two ways that we can get this virus. One of them is via what we call droplets, which are larger particles coming from sources of patients that tend to fall in the floor very, very quickly. And we've read now from papers that it can survive in surface for a long time, up to 3 days in plastics. And we have also aerosols generated by the source, by patients, and they are a little bit more complicated, and I will cover this later. So how do you deal with droplets? It's fairly easy. We keep the distance between 2 and 6 meters. The further away you are from the source, the better. And we offer the physician or the care worker kits or PPE. And that includes a body protection, a surgical mask, a visor or goggles or glasses to protect from the eyes, a pair of gloves, and obviously we encourage hand washing. And we call that what we call the basic PPE. So that's what a basic healthcare professional should in theory be wearing to protect themselves against droplets coming from patients. And very importantly, we mask the source. Although this is not a wide recommendation, it's pretty obvious that as the disease is coming from the patient, the source, protecting him from exhaling those droplets is very important. Now, when you go into aerosols, a bit more complicated, and the reason for this is because small particles of less than 10 microns, instead of falling in the floor, they try and they tend to keep it in the air and circulate it, particularly in rooms that are not well ventilated. And it has been documented that following a cough or a sneeze, that aerosol circulating can stay in the rooms up to hours if no appropriate ventilation is offered. Now, the problem of the aerosols, not only they can go through your masks and your visors, but they will be inhaled. And we know this because aerosols is the way we use therapy for asthma, for example, with nebulizers. So particles small as 10 microns will go all the way down to your lungs, and that's really a problem for us. Now, we hear a lot about aerosols generating procedures, or AGP, and what we have to understand as well is which environment creates what we call the aerosol-rich environment, and we're trying to explain this in a diagram. We all know now from the experience of the Chinese that leaky, non-invasive ventilation is a very intense aerosol-producing procedure. We know CPR and intubation are there as well. But we're also learning that coughing and sneezing are also generating aerosols, and this is particularly relevant for echocardiography as the operator will be very close to the patient. And you also learn now from experiments that even talking loudly can generate aerosols, albeit in smaller amounts. And when you look at the environment, we obviously know that being outside in an open air, it's a much easier way of getting rid of such aerosols. If you can work in negative pressure rooms, we'll also remove these aerosols actively. And if you work in a very large, externally ventilated ward, that's also a good sign. Now, small side room with no windows would be the opposite, would be a perfect environment for aerosols to be circulating. And we have to ask ourselves where our ITU or CCU, a cardiac ward, in particular a cath lab, fits within that spectrum. Now, what can we do about aerosols? We have to gown up a bit more, put what we call surgical hoods or protect our head and face. We have to have respirators being FFP2s or FFP3s to prevent those aerosols from going through a surgical mask. And we have to have very tight sealed goggles to prevent the same aerosols from getting in contact with our eyes. And that's what we call the full PPE. Although, of course, the definition of PPE is quite ambiguous. Different countries, different places, different hospitals, you use different things. And you can have a spectrum from going from all the way from the very basic of a surgical masks, all the way to, we can see from Chinese and South Korean videos of using a full body kit that doesn't leave any millimeter exposed. So what you have to think is, what is your reality, what is your need and your policies when you think of implementing your strategy? So what are we doing at Imperial? We are dividing essentially our PPE strategy in two. One into a basic PPE strategy, which has surgical masks or respirators, a simple a cap, some protection to the eyes with goggles or glasses, a basic gown and gloves, obviously. And a full PPE we are calling, doubling that, 2 gowns and 2 gloves, a full respirator, having a face shield, but also, very importantly, protecting your eyes with goggles which seal the entrance of aerosols. And we're doing that for all patients who we either confirm or suspect to be COVID positive. And we leave the very basic PPE only for patients who are green or very unlikely to be COVID positive. Now, asking for any evidence, there's a few papers out there, if you want to be cherry picking, suggesting that using respirators gives you more protection over surgical masks. But the whole argument against evidence, in my view, is there is simply no robust evidence that an inferior PPE is equivalent, and therefore it's very logical and safe to assume that a better PPE will give you better protection. So in terms of practical messages, we can say that a basic PPE should be made of surgical masks, gloves and glasses, hand wash and distancing against droplets. More advanced PPE should involve sealed goggles, full FFP respirators, head and body cover, and that is needed for aerosol generating procedures, particularly if you're going to be working in an aerosol-rich environment. And mask in all patients is something we've learned from our colleagues in Italy as well, because they are the source of the problem. And the rule it is, if you have limited cash, really you should buy the best that your budget can buy. If you find problems of supply, you can buy the best you can find. But if there's no limitations in terms of cash or supply, you should really think of getting the best PPE kit that you can implement and be operational in your cath lab. And a very important point here, do not take for granted how difficult it is to get your staff fully trained on this. So train your staff on how to use them, in particular on how to remove them after a case. And you can check on YouTube for some of the videos we've created here on how to put on and remove our PPEs during cath lab procedures. And I will stop there.